Hello, everyone. Can you guys hear me through the microphones? Excellent. So my name is Sumitra Khandelwal. I'm at Baylor College of Medicine. Take care of a lot of tertiary care, cornea, and always excited for some new technologies out there to help our patients, especially really struggling patients who have issues like persistent epithelial defects. And so I was very excited to hear about this product a few years back, and even more excited to utilize it quite a bit in our clinic, not just at Baylor, but also at our VA and now at our county hospital as well. So we're talking to you about the BrightMEM allograft, kind of go over the scientific background, but most fun part is actually kind of getting your hands on it to actually take a look at a procedural video more so. My financial disclosure includes BrightStar. So this is a novel cornea allograft, and it promotes re-epithelialization of the corneal epithelium. And there are so many different options out there now to heal the cornea, but we all have those patients in our practices that it's a real struggle on what to do with them, both short-term and long-term. This product, it's made of decimase membrane, which makes it very unique. It creates a foundation, and it's kind of a scaffold that then can allow for limbal epithelial cells to be supported. And so it's really kind of changed our practice and what we do with some of these patients with tougher, persistent epithelial defects. It's available through BrightStar, but we can actually utilize it through other eye banks as well. We get ours through a different eye bank that works with BrightStar. It's coded actually as an anterior lamellar keratoplasty, and that's really key. I actually had a case the other day where there's a little confusion about, are we trying to order ALK tissue? Are we going to order BrightMEM? And so you want to be very clear about that. But the coding is, in fact, for anterior lamellar keratoplasty with a very good tissue reimbursement and cost and pass through to your surgery center. So who's that ideal patient for BrightMEM? Well, the patients who benefit the most are ones that have these persistent corneal epithelial defects, but kind of think of it as treatment plus. There's other unique groups within this class that I think truly benefit from this. Patients who have partial limbal stem cell deficiency, patients who have neurotrophic keratitis. That's been a huge population for me that I've utilized this on, whether it's neurotrophic keratitis from prior surgeries or whether it's zoster or HSV keratitis, or even patients who are like prolific diabetic retinopathy patients. I think the last two patients I did actually had really bad diabetic retinopathy, and the retina specialist was looking for a way to get a better view of the retina, and things that I had in mind wouldn't have really allowed for that. They weren't really good visual potential wise for a PKP. And so this allows sort of a clarity to the posterior pole by also allowing healing for these tough cases. And even just chronic epitheliopathy, I think that always goes a little bit underutilized. I'm always amazed at how patients who have really bad ocular surface disease, their epithelium just constantly changes and remodels in front of you. You can actually take a bandage lens off of them and keep them in the clinic for like 15 minutes, and then their epithelium looks completely different, for example. And then patients who have medicamentosa and toxicity and stuff. In my practice, it's really been key for the neurotrophic keratitis patients, the partial limbal stem cell deficiency patients, patients who've tried a few in-clinic ways for corneal epithelial defects. I'm keeping this in the back of my mind as sort of where we're going to go direction-wise if we haven't healed after a few weeks. People say persistent epithelial defects. I mean, that's okay. At some point, the epithelium will heal. What I'm always looking for is to make sure that we heal the epithelium before we start to get subepithelial haze, subepithelial fibrosis. That's something to always look for. Some patients develop it within a few weeks. Some take a few months of having a persistent epithelial defect. And so that's been really key for our patients too. What are our current treatment strategies? We have a lot. They're not all that great, but some of them are more easily accessible in your clinic. Changing the medications they're on, moving to preservative-free, moving to procedural things, treating any sort of coexisting pathologies such as lid, margin disease, but also lid anatomy, for example. Changing their drops if they have infection, for example, quickly going from something like a fortified to a preservative-free option once the infection is cleared, treating aqueous deficiency, and really these treatments for aqueous deficiency really go hand in hand with persistent epithelial defects. So I certainly use them in conjunction with BrightMEM. I use them maybe as a first line before we go there, or sometimes I'll even go in and do a BrightMEM and at the same time do punctal cauterization at the same time. At the same time, consider some sort of treatment post-operatively with gels and ointments and such. And we utilize a lot of serum tears. We use a lot of plasma-rich growth factor at our practice. And we use scleral lenses a lot for these patients, actually. But at the same time, that's a lot to ask of a patient all of a sudden to use things like a scleral lens. And so this has been really good for our patients. I have a few patients here where we have them, they have kind of a persistent epithelial defect that will heal with the bandage lens, and then see them back and they got to replace the bandage lens, and then suddenly I have this patient coming in my clinic every 3 to 4 weeks, and all I'm doing is changing out their bandage lens. And I start talking to them about options like this as a way to kind of end that cycle of constantly needing some sort of barrier to protect that epithelium. And then also the other key, which has been shown, is to rehabilitate some of these existing limbal stem cells in a patient who's got stem cell deficiency, especially in focal areas. And with that, these are some preclinical studies. What are some of the advantages of this over something like, say, an amniotic membrane, for example, or doing like a full thickness PKP, which can certainly have some risks with it. Well, this is optically clear. And I think that was the part that I wasn't sure. I was a huge believer on it, but it's so clear, which is really great, especially if you want to keep, the view of, the posterior pole. Some patients who got like persistent epithelial defects and also had like bullae, we've been in the past using things like ablation with PTK and kind of ablating that top 20% of the cornea to stop them from having these bullae. But the challenge is you've really given up on the view of the posterior pole for those patients. It's quite a bit of haze that they get. Your goal is to actually get haze. So we really switched those patients over to doing something like this. There's also the extra component to it about the actual property of the membrane, more than just, say, a coverage sort of situation. It actually has these fetal banded layers that express limbal basement specific proteins. And that really serves more of a long-term substrate to really support the limbal stem cells. So that's the extra thing about it that kind of differs it from, say, just a typical barrier. Studies showing that there's collagen chains that are very similar between the limbus as well as this BrightMEM. And when you look at some of these studies looking at confocal microscopy, for example, in the lab, you'll notice that there's some expression of ABCG2 marker and K12 marker that kind of showcases how this does more than just act like a barrier, but really helps with proliferation, migration of these limbal stem cells. This is a very unique photo. I really like this. It kind of is the anterior segment OCT showcasing its use in these chronic persistent epithelial defects and how it can act like a barrier, but also prevent corneal thinning and stromal melting. And so on the leftmost picture, on the top there is before a collagen enzymatic digestion is given. So basically in the lab setting, they're creating a situation where they're creating a stromal melt. And you can see going from 569 in the control, when you add this, it thins quite a bit. And amniotic membrane is something that we still utilize, and it can be used in conjunction with this. But we have utilized it in the past to cover some of these really tough recalcitrant persistent epithelial defects. But it dissolves, and especially if you use it just in an onlay technique, it's not going to be a barrier to thinning. And so you can see here when you add that degradation of the stroma, it thins quite a bit, versus the Decimase membrane, the BrightMEM, provides a barrier. It still thins a little bit, but it provides a barrier, but also protects against that stroma melting. So that's really one of the differences between the two. You certainly can utilize them together. I've utilized them, and I can give some examples later of how I've utilized amniotic membrane more to add a little bit of additional scaffolding because the epithelium needs to heal on top of this. And so I think it's going to be really challenging to heal. I'll use the BrightMEM and then the amniotic membrane on top. And I've also used the amniotic membrane to kind of fill craters in the cornea and use the BrightMEM on top of that. So various different ways. Here's another study that's kind of looking at the collagenase degradation, laboratory studies, looking that after about 30 minutes, the BrightMEM is still there compared to amniotic membrane alone. With the tissue scrolls, it still provides a barrier. It doesn't dissolve. Like, say, sometimes with the amniotic membrane, sometimes it's a variety of when that amniotic membrane is going to dissolve. Sometimes it dissolves within a few days. Most of the time it dissolves in a few weeks, but here this does not dissolve, which is great. One of the things that I've been kind of surprised about too is looking at not just how it kind of protects and acts like a barrier, but also, the components of it that allow for, improvement in things like neovascularization, for example. So here you have this patient that has neovascularization. This is a rat model, actually. And basically, the superficial keratectomy is performed, the BrightMEM is performed after that. But even some of that peripheral neovascularization, some of that scarring improves as well. And, we see that with other products as well. Like you think about, things like recombinant nerve growth factor. I mean, the goal of that is to heal the epithelium, but we see improvement in the haze, and we see improvement at times with the neovascularization. That's not really what the studies looked at per se, but we see that on a clinical basis. There's something about promoting healing and also promoting the limbal stem cells that allows for improved haze, improved scarring, and improved neovascularization for these patients. So here's the fun stuff, the clinical data. So, it's still a relatively new procedure. It is one that has a very quick learning curve. In fact, Joe was excited to know that, I had done one, and then my fellows, both last year and this year have each done a couple now at this point. And so it's not something with a huge learning curve, but there are some little nuances as well. And so I think it's really an applaud that they've been rolling this out in a way and really teaching surgeons tips on how to utilize this in their OR. And so with that, we've learned a lot about the first 200 plus cases here. Limbo stem cell deficiency, as I mentioned, is one of the big indicators for it, as well as persistent epithelial defects. And for us, some patients it'll definitely help as far as pain. I mentioned the bandage contact lens patients, where I'm constantly kind of changing out their bandage lenses every 3 to 4 weeks for things like painful recurrent erosions or painful epithelial defects, but also for the neurotrophic patients as well. With the initial 100 plus cases that they reviewed, 91% had fully healed epithelial defects. And, there are a couple of patients that have had graft loss or retention. I've had one, and I remember quite clearly I could have probably done things a little differently and maybe educated the patient a little bit more about eye rubbing. One of the keys with this is there's a learning curve, and it looks so great, maybe the first day afterwards, their graft kind of dissipated, slipped a little bit about 3 weeks later, and I think it was due to patient rubbing, but also they had a very irregular cornea as well, and I think I could have done a few things at the time, some tips that I'll show you on the video that we've now since learned to help make it so that the graft doesn't have many folds, is really nicely adhered on there. Don't use too much glue, use just enough glue. Little tips that you learn after doing a couple. But we've been really, really happy. One of the things, at least in our practice, though, that we still have to work hard for these patients is making sure their epithelium grows on top of the BrightMEM. Definitely acts like a great scaffold, but we will utilize things, bandage lens, amniotic membrane if we need to, sometimes even a tarsorrhaphy for these patients, because the epithelium should heal over. And once it does, you kind of feel a little home free as far as the placement and where the graft is located and the risk of graft loss. They have about almost 50 cases now beyond 6 months. Once it's kind of healed in that initial period, then you can be pretty assured that this is where it's going to be more long-term. So this just talks a little bit about central staining. This is a smaller series that was presented at World Cornea Congress, and essentially just showcases the improvement in central grade staining, improvement in visual acuity scores, which actually I was very interested to know about. I will be honest, our first 5-6 patients that we did in our practice, they didn't really have great potential visual acuity. They were glaucoma patients, retina patients, potential being more like hand motion, count fingers at most. And some of them did get some improvement. I had a couple of retina specialists who were very interested in this product because the patient had persistent epithelial defect, the prolific diabetic retinopathy patients before, the epithelium was irregular, but there was also that subepithelial haze. And once that cleared up, once their epithelium healed over it, even through the BrightMEM, they just had a much better view of the posterior pole. So that's something else to think about too for these patients. And then they had improvement in this series of corneal neovascularization from 71% to 5% with no persistent epithelial defects post-op. This is a case. This is a patient who has a history of limbal stem cell deficiency from a chemical burn. You can see, not complete limbal stem cell deficiency as several quadrants still remain clear, but they've got kind of that, multi-clock hour approach where now you have haze that's growing into the central visual acuity. And you look at this and it's like, just remove it. But I mean, we know that if you do switch keratectomy and remove some of these kind of pseudopannus or scarring, it's very, very challenging for the surface to grow back. And oftentimes you're really holding their hand. And also it doesn't really heal up the underlying issue of that focal limbal stem cell. But then post-op, you can see the improvement in the central cornea, but also the improvement of some of that neovascularization peripherally. Now, there's still a small little quadrant down there that you can see some haze, but that's not really visually significant for this patient. And their vision improved from hand motion, from that central kind of scarring to 2200, which was a huge improvement for this patient. Here's kind of the key. It's like the money slide. This is the learning curve slide. So what are we going to showcase in the video in a little bit? So the BrightMEM comes, from the eye bank, very similar to PKP or DSEC tissue. It's got an S stamp because, it's pretty easy to get on top of the cornea, but it's always nice to have that, not just for orientation really as much as also visualization. It's such a very thin tissue. Although it's got no cells on it, decimates can be pretty tough sometimes to see even in the chamber there. Your first step is to do a really good superficial keratectomy. You want to be at least 1 to 2 millimeters larger than the area you're going to cover. So for example, if you see okay, I really want the central 7 millimeters is where we're having a lot of problems with this patient's cornea with recurrent erosions, persistent epithelial defects. You want to go 1 millimeter or 2 millimeters larger than that in diameter, because you want the BrightMEM to kind of sit kind of like an inlay technique underneath the epithelium, and then let the epithelium grow around it. And so we take a lot of care to really remove the epithelium, check with the WEC, make sure we don't have any little nests at the time, and to really make a large enough superficial keratectomy. The corneal button, you can take it, tree find that. So I'll show you there in the video. So for example, we're going to do one where it's 7 millimeters, going to be the tree find. So like I'll make an 8 to 9 millimeter superficial keratectomy, a nice ring around it, and then take that in the tree find and tree find 7 millimeters, just like you would do for a regular graft. Before you tree find, you want to make sure it's not folded. There's a few little tips to make sure it's not folded. The thing about it that I was really surprised, and I had called Joe about this the first couple of times, is I was so scared to touch that tissue because, I mean, we don't touch Decime's DMEC tissue, right? We you're taught not to do that. But this has been processed, so it has some rigidity to it. If you, a little trick is to take tying forceps and to just kind of move the graft, with the tying forceps closed, so you can centrate it, so you can take the folds out and such, and it really doesn't tear or anything like that. I like Joe's one tip he said is don't use 2 instruments, actually. You think 2 instruments, think how many times we use 2 instruments to move things, but it's that torque, that pressure that makes tears and stuff like that. So really just use 1 instrument, and don't be afraid to touch it with a non-toothed forceps, because it actually can withstand. It's withstood several of my fellows and done just fine, actually. So, and then, you want to place it face down. So you want the Decime's to be, against the area where the epithelial debridement is. And then you want to let it dry. And this is the part where you have to be patient. And you want to wick fluid from the interface at this point in time and make sure that it's as dry as possible here. And once you feel like it's fairly dry, then you can remove that stromal button. And then you're left here with this, with the BrightMEM here, over here on the epithelium. And now you can take a little bit extra time to smooth it, to dry. Little tips that has been shared after these first initial cases is sometimes, you'll see it and you'll be like, oh, wow, the edge is folded and it's kind of folded on top, for example. And you can just usually use the non-toothed forceps to just kind of smooth it out. If it's folded underneath, it's not really easy to just squeegee it on top, so it's actually better to kind of move the graft a little bit, let that underfold go back to the right orientation, and then move it back, for example. And we'll just kind of look at that in a second. Lastly, sometimes you'll do this and you'll feel like you dried it really, really well, and then you lift the stroma off, and sometimes it looks like perfect. Like you don't have to do very much manipulation. A lot of times it'll have like little subtle folds, and that's okay. You put a couple of drops of BSS, some of those folds will just disappear, actually. And then just kind of smooth and dry. So just kind of like a light squeegee approach to remove that. You can use like sort of a blunt instrument to squeegee out any of that. And you want it to dry really, really nicely. After that, it's really helpful to use a little bit of fibrin glue at the edges. You don't need a whole dollop of it, not like the way you would like glue in like amniotic membrane or like a conj autograft or something like that. Just a couple of drops at a few clock hours around is all you really need, and then let that dry. And then we usually do a post-op, we do a contact lens usually at that point in time. Sometimes if they're a patient who has some lid anatomy issues, we'll do a tarsorrhaphy as well, because you really don't want exposure on top of all of this or the bandage contact lens to fall out. So we'll do either a suture tarsorrhaphy or we'll do a tape tarsorrhaphy at the time. And for patients who I know really don't heal that well, sometimes I will add a layer of amniotic membrane on top. I kind of prior authorize for some of the patients, especially some of these patients I've known in the past have sort of failed just traditional treatments. I'm just looking for one extra way to get that epithelium to heal on top. And in general, contact lens works pretty well. So super excellent. And so, we're really excited about this. I think I'm going to show you a video now at this point in time. The demo? Yeah. Excellent. Super. Fantastic. That's what I meant. Live video. Yeah. Live video. Excellent. Okay. Penetrate. I'm going to penetrate very well. You mean into the aqueous? I have not seen patients who've had like pressure spikes afterwards. We're usually covering them with moxifloxacin and a low dose steroid. If you think about it though, let's say a 7 millimeter graft all the way around there. Their cornea is still open for penetration and stuff. I'm not sure, I don't think it's any different, definitely not any different than like a bandage contact lens, for example. But I'm not sure if there's any studies showing drop penetration.
Study, but remember, you got a bandage contact lens on there.
Yeah.
That's limiting more than the graft.
Yeah. And the peripheral, I mean, there's usually a peripheral cornea that's still also open. Other questions before we do our demo here?
Not well, like a very superficial scar, would that help that? Or?
So that's a really great question. So it depends on what the scarring is from. If it's subepithelial scarring, sometimes I'll do the superficial keratectomy and just do a little bit of burr on that area, just a light burring, almost like I'm in the OR, but almost like a light PTK, just to kind of get rid of some of that very, very superficial scarring. I mean, I don't have any study comparing if it's worth it or not, but I've got that in my OR. I think, though, one of the keys is, do you think it's reactive haze or reactive scarring from the persistent epithelial defect? Or was there an underlying reason why they got that scar to begin with? I'm always amazed, and I think we all see that, like, take a patient who's got like some anterior stromal subepithelial scarring and you do like a DMEC on them. And then like 6 months later, that anterior pathology starts to improve a little bit. And so it's really interesting because what it is about anterior corneal haze, how much of it's reversible versus not, it's just always fascinating to me. So I think it's worth it if you remove the epithelium and you see some light haze scarring, I'll probably just do a diamond burr and just kind of see if you can't. You're going to cover them with an antibiotic and a little steroid. Obviously, the burr is a little more inflammatory. You're going to cover them with a steroid afterwards, oftentimes too. But great question. Excellent. Super. So this is, let's see, you got the eye here. So I'm going to switch over real quick from the fake eye to what it looks like in the chamber here. So you see the S stamp there, and this graft is nicely oriented. If you can see it a little better if I lift it up right now. So I'm going to point out real quick, so it's very nicely oriented here. If you see right here, it's got a slight little fold in this area. So I'm going to kind of keep an eye on that. And then kind of, as I take this graft out, get my pink gloves. Thank you to whoever got size small pink gloves for me. Open it as usual. So we've decided, my first step is always to like measure, right? It's always fun to keep going with the case. And then at the very last minute, be like, and I need the 7mm trephine. So I always sit down and first step before I even do like a subtenon's block, if I need to, is to say, this is what size I need from my technician. And then let me just double check these teeth. Yes, super. Excellent. And so I'm going to bring this over. Oops. Sorry, guys, made a mess here. You want to get the fluid out and then lay it down here, just like you do. Excellent. So it's off the screen. Perfect. So that's what it looks like here. And then I'm going to trephine it. It's really important to use a suction trephine. The first one that we did at our VA, I don't know, they didn't order the suction trefines because, I don't know, they just don't have them there. I know I didn't suction it just now, but that was one of the ones where we had that kind of folded over. It still turned out great though, but it's just something to kind of keep in mind. Okay. Let's see, is this in focus here? Super. And now I'm going to focus this over here. And so now I've got the BrightMEM here, and it's slightly folded. And then I've got a superficial keratectomy. I've already done the superficial keratectomy, to be clear. And so now I'm going to dry it a little bit. I'm going to put the BrightMEM on top. Sorry, the eye's a little angled there. I'm going to dry it real quick. Actually, this is a good example. So right now the BrightMEM is slightly folded underneath there. So I'm keeping my eye on that a little bit. And I may actually go ahead and lift this up in a few seconds after I've dried this in order to centrate it. Let's see which one has. So here's an example of where it didn't go perfectly, actually, which is not bad for you guys to see here. And so now this graft here, it is not quite in the center yet. So I'm going to put a couple of drops of BSS. And kind of roll it into place here. Then I'm going to take my non-tooth forceps. So I've got my tying forceps here. I'm just kind of straighten it out. So now it's in a really good position. And you see how I've manipulated it pretty tough. I would never do that with like DMEC tissue, for example. But because this tissue has such great here and it's really pretty robust, we're able to kind of put it in that perfect position. And now this is the part where you get to wait. You get to dry. And so we've actually, I don't know, in the beginning we were waiting for like a minute and then touching it a little bit to see if it moves. And then we're doing like 2 minutes. And I think at this point in time, we're kind of waiting for about 3 minutes or so, kind of drying all the way around, putting the little bit of Tecile. We utilize that time to then give some Ansef or Decadron or some sort of injection at the time for the patient, get the contact lens ready and such. And so this is kind of the time where you have to kind of be patient, wait, make sure the orientation is there, and then put your bandage lens and then go from there. Super. Joe.
Share some squeegee.
Some squeegee. Excellent. So let's see. So this is you could use this to squeeze. You want to be real gentle as you squeegee the fingertip. Excellent. Super. Questions?
You put a few drops of the glue on it and then contact on.
Yeah, I usually do like just 2 drops, maybe 3 at the most, and then the contact lens on after that.
How long do you keep the contact lens on?
I check them at 1 week. I do not take the bandage contact lens on. So I see them at 1 day. I see them at 1 week. I see them about 3 weeks or so, 4 weeks, and then I'll change out the bandage contact lens. What I'll do is I'll take out the bandage contact lens, take a look at the patient to see if there's an epi defect. If there's still an epi defect over the BrightMEM, put another bandage contact lens off. But I will actually keep the patient for about 5-10 minutes in the clinic just to make sure, because sometimes when you remove that contact lens, you actually cause a little bit of epithelial trauma a little bit too, and then you'll actually see the defect afterwards. I feel like some patients have healed within a month with the bandage contact lens. We've had some that have taken about 3 months, actually. I don't know if Joe can jump in with his...
I prefer you not be a curious George. We've had people take off a contact too soon and disrupt or move or wrinkle. Leave it for 30 days. No one's had a problem for 30 days.
Yeah.
Sometimes you'll see edges of healing come in. So because we leave it on 30 days, you're not checking. Our mean healing is 34 days. We can't get under 30. Just